going to talk about a topic which is rare in pediatric practice, but one which can have significant consequences overall. That is about thyrotoxicosis. So how common do you think, Dr. Vibha, is thyrotoxicosis in pediatric practice?
So thyrotoxicosis is basically very common in pediatric and it's not common in adults.
Yes. So roughly it's like 1 in 100,000. That is the sort of a figure. When we say thyrotoxicosis, we used to earlier use the term hyperthyroidism. So why don't we use the term anymore, Naveen?
Sir, basically thyrotoxicosis is elevated levels of thyroid hormones. This could be basically because of the increased production or because of the increased release. Hyperthyroidism basically increased production of the thyroid hormone.
So when people used to say hyperthyroidism, it would basically mean that it is increased production. But we will discuss that many causes because of destruction of thyroid also, which is there. So what we'll do today is that we will use different case scenarios to highlight about the complexities in terms of etiology, evaluation, and management of thyrotoxicosis. The key question is it thyrotoxicosis? What is the TSH status? What is the cause? We'll go step by step from there. So to identify thyrotoxicosis, you should be aware that when should you consider. So most of us know that if there is weight loss, if there is hyperdefecation, if there is tachycardia, tremor, sympathetic activity, we start thinking of thyrotoxicosis. But you should also be aware that if you have periodic paralysis, you should always think of thyrotoxicosis. And we'll discuss about one of those cases which may happen in that regards. Polyuria is also a manifestation of thyrotoxicosis, easy fatigability, worsening of overall school performance, myasthenia. These are all other indications where thyrotoxicosis should be considered. If you have sudden rise in thyroid hormone, you will have a lot of problems which is known as thyroid storm. So in this scenario, if your thyroid was uncontrolled and you do a surgery or you do a radioactive iodine, suddenly a lot of thyroid, which is already there in the thyroid, will come into the body. And that is going to cause the thyroid storm. It can also happen in infection settings. Your levels of thyroid will go hugely high, up to 100, 200, 3, 4, 5 times, 10 times the normal. And that will basically cause a significant problem in the form of cardiac failure, hyperthermia, tachycardia, palpitations, atrial fibrillation. So all those complications will be there. There could be encephalopathy, arrhythmias, and you will have hyperthermia in that regards. Now, which test shall we do to screen for thyrotoxicosis, Dr. Vibha?
TSH, T3 and T4.
Yes. So very importantly, as discussed, in cases of thyrotoxicosis, the TSH will be the first to go down. T4 will rise, but the rise of T3 will be much more. So if you just do FT4 TSH, you may still be confused. So in this scenario, you should do T3, FT4 and TSH. Why T3 and not FT3, Dr. Nani?
FT3 is not really.
So most assays of FT3 actually use a surrogate marker using T4. So they are not very good. So T3 total is what is recommended. Now the next status is it because of relief or production? So we need to know where the signal is coming. Is it TSH dependent or independent? Anybody whose FT4 is high, TSH should be 0, less than 0.1. So if it's undetectable, this is thyrotoxicosis. If it is on the higher side, any detectable, it is a TSH adenoma or resistance. This is what we've discussed. These are less than 0.01% of cases, so we won't be bothered about that. So most you will come there high FT4, low TSH. This is the typical picture you will see. Now, from there, the biggest question that you have to answer is it Graves' disease or it is thyroiditis? That is the big differential to look at. So in thyroiditis, because of antibody, viral infection or bacterial infection, there is a damage. There will be no eye signs and goiter. It will be a milder disease, which is self-limiting. There will be no radionuclide uptake in that scenario. While if you have Graves' disease because of a stimulating antibody, you will have eye signs and goiter. It will be a severe disease. There will be increased uptake and you would require antithyroid drugs to treat. So just to distinguish if it's a rapid course, if you have eye signs, if you have goiter, you have got very high levels of FT4, you have got bruit, which is a marker of vascularity of the thyroid gland, you are mostly dealing with Graves' disease. If there is a milder symptoms, absent eye signs, absent goiter, no bruit, marginally elevated FT4, it is most likely thyroiditis. Dr. Ruchira, what is the most common cause of thyrotoxicosis with eye signs? You've got eye signs and thyrotoxicosis. Most common cause? Graves, we've discussed that. Na? Vibha, what is the most common cause of thyrotoxicosis without eye signs? Yes, so you need to remember that even if the eye sign is not there, it can still be Graves' disease. So you cannot just say no eye sign does not mean that this is a thyroiditis rather than a thyrotoxicosis. So radionuclide scan will tell you the picture in that regards. So pointers against Graves are no goiter, age less than 1 year. So less than 1 year, like in diabetes, we say if the age is less than 1 year, think twice before you say it is type 1. It may be a maternal passage of thyroid or a TSH receptor activating mutation which can cause that. And that will give you a picture. Now, what about TRAB antibodies? There are two types of antibodies which are measured. One is a TSH receptor antibody. The other is the TSH stimulating immunoglobulin. TRAB versus TSI. Some people say TSH binding inhibitory immunoglobulin, TBII. What is the difference between TBII and TSI?
Basically, one is basically bio and the
yes. So when you say it is binding the TSH receptor, it can both activate or inactivate. But to prove that it is activating, you need a bioassay. So basically, immunoassay, you just see whether it will inhibit the TSH binding or not, which is the assay which is there. And you will study that. This is a low cost now available in most platforms. You can do this antibody. It will not tell you whether it is increased production or not, because it can be both blocking and stimulating. But suppose you have somebody with Graves' disease and these antibodies are positive. It can't be blocking antibody. It has to be stimulative. So if you use clinical sense, you can use this also and get a good idea based upon that. Bioassays are actually, you will use specific cell membranes which are going to produce cyclic AMP. So it's going to be very, very complicated. Your trap will go there, it will start acting and then levels will go up. This is definitely gives you a functional status and it is very, very expensive. So the sensitivity, which one will be more sensitive? Trap or the functional ones? Immunoassay will be more sensitive. Specific would be the bioassay because it will only be positive in Graves. It won't be positive in thyroiditis. So if you have classical picture of Graves and somebody says, okay, stimulatory antibody is negative, you can then do a TRAB and you will know that this is positive because it's more sensitive. But I would say there is very limited role in routine clinical practice to measure antibodies, which condition it is very important. So in the pregnancy, so during pregnancy monitoring of mother, this will tell you how much likely is the baby to develop those complications from that regard. So Graves versus thyroiditis, limited role, more in terms of pregnancy. And earlier people used to say, okay, now the antibodies are negative, we can stop treatment in that regards. So thyroid scan is very important. We can use both iodine and technetium. It should be done if you have no eye signs and no goiter. And if you have a specific nodule, if there is no uptake, this is thyroiditis. If you have increased uptake, it is Graves' disease. You may have a toxic nodule or you may have a toxic MNG, which will give you the diagnosis in that regards. What about ultrasound? Limited role of ultrasound, largely if somebody doesn't want to go for a thyroid scan, which can be one condition in which a female will not like to go for a thyroid scan, or you would not recommend them to go for thyroid scan. So if you have a pregnant woman with thyrotoxicosis, if you have a doubt, then you can look for the blood flow vascularity. The other role where it is very effective is amiodarone-induced thyroiditis. There are two types of amiodarone-induced thyroiditis. One is thyroiditis, second is increased production. So their blood flow causes gives you a good information. So nodule and goiter can also be characterized in that setting. So before we start with cases, the approach, first thing is to look at nuclear scan. If somebody has got a big goiter, eye sign, very high FT4, you may say, okay, I don't have a facility easily available. I don't need to do it. Otherwise, scan should be done. Increase uptake with a solitary nodule is a toxic nodule, multiple areas toxic MNG, and if it is diffuse uptake, it's Graves. If it's decreased uptake, look for tenderness. No tenderness, chronic. Yes, subacute, very, very tender, very severe. That's a rare scenario of acute thyroiditis. Interesting case which has got a management issue. And Dr. Vibha, please come up and discuss about that.
11-year-old boy came to OPD with a complaints of swelling in the neck since 3 to 4 months and a weight loss and weakness since 1 month. He complained that his swelling gradually increases in size. He has some mild discomfort during swelling, and he also complained that he has lost some 2 to 3 kg weight in this last 1 month, and he remained tired in spite of having good appetite. He also noticed that he has increased sweating and increased intolerance to heat and anxiety in these last 2 to 3 months. There was no history of any drug intake, any radiation, no history of any thyroid disorder in the family. And there is a...
So if you have a child who's got a thyroid swelling and a weight loss, that directly would suggest it's more likely to be
great thyrotoxicosis. Yes, sir. And in the past history, there was no history of similar complaint. On the examination, his vitals were, he was afebrile, but the heart rate was in the higher side, like 100 per minute. Respiratory rate was 24 per minute. BP was 120 by 76. This systolic hypertension is greater than 90th percentile for his age and height. There was no eye sign. Fine tremors were present in hands, and there was no edema. And on the neck examination, during inspection, diffuse midline neck swelling was present, which moves with deglutition. And in the palpation, each lobe 5 into 3 centimeter was there, and they were firm, non-tender, mobile, and no lymph nodes were palpable. On the percussion, there was no substernal dullness, and all auscultation brew was present.
So what do you think this is like a thyroiditis or
so thyrotoxicosis, because brew suggests there is increased vascularity in the gland.
This is clearly towards Graves' disease. So would you do a scan in this case?
So scan, because there is increased vascularity, it is more towards the Graves' disease. So there is no role of scan.
Essential. If somebody wants to do, they can do.
They can do.
Not going to make a difference.
Anthropometry shows that he has lost 2 to 3 kgs weight. So his waist is weight SDS is minus 1.66, and this investigation shows this T4 is greater than 30 microgram per DL, and TSH is 0.04, and the USG thyroid shows heterogeneous echogenicity and increased vascularity.
So if you see that there is increased vascularity, along with that a very high T4, which will basically show the report. So very high T4 level, which will basically suggest that there is more of an increased production along with increased vascularity.
Yes,
which will suggest more like Graves' disease. So how will you treat now from this?
So this is clearly showing that this is the patient which came to us with a Graves' disease. So we'll start, and he also has the sympathetic symptoms like in the form of tremors and this tachycardia. So we'll start with this beta blocker to decrease the sympathetic system, and with the anti-thyroid drugs. And
what would you like to do at the baseline? Which investigation will you do before you start thyroid?
So before starting the base anti-thyroid, we should get this WBC and this liver function test done, because
these can be affected in thyroid disorder.
Yes, sir.
As well as because of drugs.
Yes, sir.
So you should get a CBC and a ALT level done. SGPT should be done before you start.
Yes.
Now what dose will you start?
So in the initial dose, it should be high between 0.6 to 0.1, but as the thyroid function comes to normal, like FT4 in the high normal range, we decrease the dose to the 50%, and in the maintenance, we made it to 0.5 or 0.2 to 0.4.
So the dose which is recommended is 0.1 to 1 milligram per kg. But generally giving higher doses are not going to be beneficial. Why is there a lag in response? When you give anti-thyroid drug, your levels do not become normal quickly. Why?
So because the in the glands they are already preformed.
So it is
thyroid
not that if
hormones.
you increase the dose, your response will be better. It will take time. So giving 1.5 is not going to help. So don't give too much dose. 0.6, 0.7 is good enough. Now, what is the difference between PTU and methimazole in terms of their action?
So PTU it is to both to decrease the production, and PTU also it also decreases the conversion of the this
In
T4 to
PTU, it
T3.
may be relevant because it decreases the conversion of T4 to T3. So there giving high dose may be beneficial. But now we don't use PTU because of hepatotoxicity. There is no role of PTU unless there is a contraindication to methimazole and you are waiting for radioactive iodine or sulfate. So methimazole you should give, but not give too high dose because all the side effects are dose dependent. So you have to be careful on that. So now you go ahead.
We started the methimazole with 0.7 mg per kg per day, and along with the beta blocker. He developed itching and arterial rashes all over the body after 2 weeks after starting the treatment. And he has no history of any asthma, food allergy, and he hasn't taken any drug in between. So as we all know that the most common side effect of methimazole is urticaria. So what we have done, we given.
What is the usual prevalence of side effect?
Sir, it is like 30%, around 30%
may have urticaria. What is the other thing you will tell the patient before you are before sending him off, that if you have these things, come to me immediately?
So the patient develops fever or pharyngitis or sore throat, and then he has to come.
So any pain in the throat, that is number one with fever. Second,
jaundice.
any features of hepatic dysfunction. So three major adverse effects are agranulocytosis, which is sometimes dose dependent, but can be idiosyncratic as well. So it can happen just like that. Hepatic dysfunction, more common with PTU, but can happen with the use of methimazole also. So any jaundice, pale color stools, itching, all features of jaundice, they should come to you. And third is vasculitis. So if there are joint swelling, these things you have to come together. Urticaria is more common. It is not very serious.
Yes, sir. So we managed this with by giving Allegra, and it was given before 1 hour before the drug, and the rashes subsided after giving Allegra. And again, after 2-3 months, he developed sore throat and tonsillitis, but there was no fever. So as sir has mentioned, there is a chances of developing agranulocytosis. So we get the WBC count done, but they were normal. So we gave a course of antibiotic and the tonsillitis subsided. Then after 18 months of treatment, there was no symptoms and signs of hypothyroidism on 2.5 milligram of methimazole. Free T4 were also in the normal range of 0.84 nanogram per DL, TSH 4.02, and goiter side has also been reduced. So treatment has been stopped. Now he is in remission since 1 year.
So if you go back to the case in the beginning, don't go back, just think psychologically. Remember that. So was he a high risk of relapse or a low risk of relapse?
Sir, he was a male child first.
So male, goiter size?
Goiter size 5x3, but
reasonably bigger.
Yes, sir. And pivotal.
FT4 levels?
FT4 greater, it was a 12 or very high.
So he
high
is
risk
a
of
low chance of
remission. Yes, sir.
10%. But 10% can also be there. So this is you have to be more cautious. So how long will you monitor his thyroid function?
So for 1 year. Sir, like annually we monitor his thyroid function.
So you have to monitor lifelong because recurrence can happen later. How do you define remission in your disease?
So remission is basically normalization of thyroid function in the absence of.
For how long duration? So either the patient is euthyroid or even hypothyroid for 1 year after stopping medication. So if 1 year, so this is a definition of remission.
Yes, sir.
You can't say 3-6 months you have stopped, you can't call it remission. So you have to wait for 1 year. If the patient has become hypothyroid also, that is also remission. Which means the disease is gone, now you have got hypothyroid phase. So this clearly is a remission. So if you go by your case, this is the classical presentation. Low chance of remission, had adverse effects with the antithyroid drugs. Sore throat also happened. So we got a CPC done which showed a ANC more than 1500, which is reasonable. And now off treatment, he is remitted. So
Yes,
this
sir.
is a good sign.
And this is the thyroid profile during the treatment. We get the TSH, then we can see that after we stopped the treatment on October 2021, and we get it that 1 year.
So what you are seeing here is very clear that the TSH will take long time to become
normal.
Now what you have seen is that your FT4 was hugely high, more than 30, and TSH was low. But despite correction of FT4, your TSH was still on the lower side. So don't treat low TSH.
Yes.
As soon as your thyroid becomes normal, cut the dose to half. Otherwise, your TSH will really become very, very high. What is the problem if your TSH is high? In what condition you don't want TSH to be high? If you have a eye sign. If somebody has an eye sign, if your TSH is high, they will burst. So you don't want high TSH.
Yes,
so this is a classical picture. And overall, you can see that remission happened by around 18 months, and then it will then carry.
So I just want to share this one case report. This is regarding the methmazole desensitization. This paper was published by the Department of Pediatrics in the Indiana University School of Medicine. What they have done, a 4-year-old girl came to them with a Graves' disease and with the eye signs, and she has developed rashes and arthralgia. And what they have done, as she was 4 years old, so she was not a candidate of radioactive iodine, and her parents were not ready for the surgery. So what they have done, they developed this desensitization protocol for the methmazole. What they have done, they started the prednisolone with 1 milligram per kg per day and the cetirizine, and started the methmazole with the lower dose, that is 0.1 milligram per kg, and they gradually build up the dose of the methmazole from the second day, and they have given the prednisolone for the 7 days. And after giving the 7 days, when the dose of the methmazole has reached the therapeutic dose, what they have seen that only during the course of the treatment, the girl has faced only 2 episodes of the rashes and the arthralgia. And they stopped the cetirizine after 17 months. After stopping cetirizine, she has never faced rashes and arthralgia, and she is now able to tolerate the methmazole. And
so this was a very challenging situation. Radioactive iodine is contraindicated less than 5 years of age. Surgery is the treatment of choice, but young children, people don't want to go ahead with surgery, so you give a combination. This case was milder.
Yes, sir.
So managed with antihistamines only.
Yes, sir.
Candy is asking the use of carbimazole instead of methimazole. So carbimazole is a prodrug. It has got similar efficacy. The dose requirement may be a bit higher with carbimazole, but otherwise it is the same drug, so it doesn't make a big difference. Dr. Adelaide Singh, can we have Graves' disease without eye sign at the beginning of the disease? Yes. So this is an important point to remember. The most common cause of thyrotoxicosis with eye signs is Graves. Thyrotoxicosis without eye signs is Graves. So it can happen. Can you come back with definition of thyrotoxicosis and hyperthyroidism? So hyperthyroidism implies that you have got increased production of thyroid. While thyrotoxicosis can also be because of release of thyroid hormone. 14-year-old girl with thyroid swelling, nodules on ultrasound and negative antibodies. We don't do the uptake here. High T4 and low TSH, she's on neomarcazole for now. What can I do in this case? This looks like Graves' disease. So I think here, what we need to do is that we should continue treatment and maybe try to see taper after around 18 months to 2 years, then we can go from there. Dr. Elizabeth is asking the prognostic factor, which did you say if not remission in 2 years, you should consider definitive treatment? Yes, this is important. So at the beginning, if you have a very young child, less than 10 years, prepubertal, male child, large goiter, FT4 is very high, and you have got a high level of TSH antibodies, if after 2 years you haven't achieved remission, go for a definitive therapy in that regards. Dr. Rajib is asking, is neonatal thyrotoxicosis, which is the drug of choice now? Again, it is methimazole along with beta blockers. That will be the main drug. You can use iodinated contrast, which can also be used in that scenario. Dr. Elizabeth is asking, how can you rule out pyriform sinus? Barium swallow. So barium swallow is considered to be the best test. So you look at, there is a connection between the thyroglossal area and the connection with the food area, and that's how you can get it from that regards. Treatment for T3 toxicosis, Dr. Rajib, again, the same treatment for any other condition, use antithyroid drugs and beta blockers. Why do we have Bruin Graves? Because of increased vascularity, which is going to cause that. Dr. Namir is asking role of T3-T4 ratio in differentiating Graves from Hashimotoxicosis. A lot of people talk about this because of the MDI activity, but this is not very important. I would say most important is eye signs, goiter, very high level of FT4, and if you have access to scan, that is the best test that will tell you whether it is a thyrotoxicosis because of Graves or thyroiditis. In the first case presentation, why don't you try the block and replace treatment? We haven't focused much on management here, but block replacement management, which basically means you block and then you give thyroxine, is no longer recommended. Two reasons. One is that you are giving too much dose of antithyroid drugs, and all the side effects, the hepatic, the hematological, the vasculitis, they are dose dependent. So if you give too much dose, you will cause more adverse effects in that scenario. And second, it doesn't improve your remission rate. So we don't use block replacement in that scenario. Dr. Kamlesh is asking why periodic paralysis was improved after IV fluid administration. So periodic paralysis basically is anywhere temporary phenomena. It will improve after some time. It usually is precipitated by a very high level of intake of glucose in this case. So if you give some potassium, they will improve. Otherwise also they will improve after some time. Now, Dr. Kamlesh is asking how long Allegro anti-allergic medication required. So this is an important issue. If it's a mild infection, like in mild urticaria, it improves after 2 to 4 weeks. But in severe cases, you may require for a long time. Months also may be required. What are the arguments to stop the antithyroid drug? So if you are on a very low dose, maybe around 2.5 to 5 milligrams of methimazole and thyroid function is normal, around 1.5 to 2 years of treatment, that is when you can give a trial. You have to monitor the child lifelong because all of these disorders can come back again. You have to be cautious about it. Dr. Elizabeth is talking about specific definition for being in remission. Yes, Dr. Elizabeth, the definition is that of antithyroid drug, for 1 year, you are either hypo or euthyroid. So you are not hyperthyroid 1 year after stopping treatment. That is how you define the remission in that scenario. So I think this was a very, very great discussion. What are the cause of polyuria in thyrotoxicosis? It is a form of NDI. So hypercalcemia, hypokalemia, and hyperthyroidism, they are all associated with impaired concentration of urine. So that causes a polyuria which happens in that scenario. So I think there were a lot of questions. We'll just have one slide on overview of management and then we will close. We'll have another session of management subsequently. So the initial treatment basically is beta blockers along with methimazole. Now, which beta blocker to choose? If you have a patient who has got history of asthma, then you should not use propranolol. You should use metoprolol, which is slightly better. Atenolol is also some people use. It is more selective. It doesn't cause CNS symptoms. Otherwise, we use beta blockers is propranolol. And we use long-acting beta blockers because the metabolism is hyperactive. Even long-acting becomes short-acting. So you may have to give up to 8 hourly. So 2 milligram per kg up to 8 hourly is there. If there is a reactive disease, you start on metoprolol. If you have some lethargy, weakness, atenolol is also good enough. You start methimazole. So there is no confusion. I would say the first treatment is methimazole. Start around 0.5 to 0.6 milligram per kg with beta blockers. Now, if you have a small thyroid, female gender, pubertal, low TRAb levels, and FT4 is below 50, more chance of remission. Opposite, less chance of remission. Now, after that, you see, yes, the patient is fine. So around 24 months, you may consider tapering and stopping the treatment at that point of time. As soon as your FT4 becomes normal, half the dose. Otherwise, you will develop severe hypothyroidism. If there is no response or there are adverse effects like hepatotoxicity, low neutrophil counts, then you have to think of alternative treatment in that regards. Now, one word about agranulocytosis, it usually happens in the first 100 days of treatment, and it is usually associated with the ANC absolute neutrophil count less than 500. So if your neutrophils are above 1500, nothing to worry. If it's 500 to 1500, in that case, you stop temporarily, start after 2 weeks. Less than 500, contraindication. Don't start ever, think of alternate treatment. Now, then if your age is less than 5 years, as was there in the case that you had presented, you will only treatment which can be given is surgical management. No other option. You can't give radioactive iodine. 5 to 10 years, you can give radioactive iodine. More than 10, definitely you can give radioactive iodine. Then if your size of goiter is huge, which is more than 80 grams, you should do surgery is the only option. While if it's smaller, you can go for radioactive iodine. Now, there is one group of people who would say if you have somebody who is beyond 10 years of age, who has got a reasonably big goiter, very high thyroid, very high antibody levels, you can also offer direct radioactive iodine therapy as a primary care. But there also you will have to give methimazole to control before you go for radioactive iodine. So I think the simplest approach is start methimazole irrespective of all these risk factors. If these risk factors are absent, 2 years, stop treatment and see what happens. If despite 2 years no remission is happening, go ahead with definitive therapy. The options are either iodine therapy, which you can think of, which is best because it doesn't require surgical intervention beyond 5 years, and no ophthalmopathy, no eye signs, and a size less than 80 grams, think of iodine. If there are eye signs or if the size is very much, go for surgery. Iodine therapy can worsen eye signs. This is something you need to be aware of. So what we've done today, we've gone through the overall aspects of evaluation and management of thyrotoxicosis using 4 cases. One with unusual presentation who required radioactive iodine therapy. The second who developed adverse reactions in which we were able to manage with antihistaminics. Third with a toxic nodule for which radioactive iodine was given. But now because of large nodule, we might go for surgery. And finally, thyroiditis, where scan clearly made the diagnosis. And the big message there was that you may have some thyroid enlargement which is there, but it is not like Graves. It is more like thyroid. It is more like a Hashimoto-like picture in that scenario.